Good morning. We will be starting with BHIDE award papers. All the participants are here. All the best to everyone. Our judge for this session is Dr. Dora Salla, sir. And I call upon Dr. Ninath Gaikwad as a chairperson. And I'll hand over the session to you, sir.
Good morning to all the participants. Hope you have the best day today. So we start with the first paper. It is scope versus scope, unveiling the battle in mastoidectomy techniques. Surabhi, Nikam, sorry.
Good morning to the honorable judges and all my colleagues present here. My topic for today is scope versus scope, unveiling the battle. Yes. So the history of endoscopic ear surgery says that Professor Ahmad Al-Gindi, pioneered by Dr. Muaz Tarabichi in Dubai during the late 1990s, was the first endoscopic ear surgery that was done. His contributions to the field have led him to being recognized globally as the father of endoscopic ear surgery. In my study, we have compared the disease clearance, postoperative outcome, and hearing improvement in operated cases of mastoidectomy using only microscopes and endoscopic assisted surgeries. Our purpose is to establish the role of endoscopes intraoperatively during an mastoidectomy for an improved disease clearance. For decades, standard surgical microscopic mastoidectomy has been very prevalent and it has shown very good results. But now, due to the advent of endoscopes, endoscopic ear surgeries or endoscopic assessment of the mastoid cavity has shown to be of vital importance due to its enhanced visualizations and visualization of hidden key areas. Our aim is to observe and compare the disease clearance, the surgical outcome, and the hearing improvement in conventional microscopic and endoscopic assisted mastoidectomy. We have included a patient of 5 to 60 years with a discharging hear or hearing loss, patients who are fit for general anesthesia without any comorbidities. In our study, it is a hospital-based prospective comparative study performed over a period of 2 years. 100 patients were posted for mastoidectomy and randomly divided into two groups, one in which we did a conventional microscopic mastoidectomy and the other in which we used an endoscope intraoperatively to assist the mastoidectomy. Intraoperatively, a standard procedure for mastoidectomy conventionally with the microscope was done for all 100 patients. Further to that, one group of 50 patients was subjected to an endoscopic assessment of the mastoid cavity and middle ear for residual disease. As we can see in the video, with the help of an endoscope, we are trying to remove the disease from the oval window and the sinus tympani and the facial rhesus region. Postoperatively, patients were followed up after 1, 4, and 8 weeks. An examination under microscope was done and we observed for a discharging cavity or an epithelialized cavity. This is a picture of an epithelialized cavity 8 weeks postoperatively under microscope. Postoperatively, PTA was done after 6 weeks and compared. In our study, most of the patients lie in the age group of 18 to 30 years. Females were 32 in number, and primary surgery was done for 93 patients and 7 patients underwent a revision surgery. Hearing outcome mean bar graphs suggest that the endoscopic assisted mastoidectomy patients have a statistically significant hearing improvement. Endoscopic examination under microscope findings suggest no statistical difference between microscopic and endoscopic assisted, although the endoscopic assisted group had a p-value of 0.02 as compared to a 0.035. This is a picture of a post-op discharging cavity 8 weeks postoperatively after a conventional microscopic mastoidectomy. And this is a picture of a dry epithelialized cavity 8 weeks postoperatively after an endoscopic assisted mastoidectomy. So, the use of endoscopes to complement the microscopes intraoperatively has a clear benefit in the visualization of the hidden areas. This helps in decision making, completion of the mastoidectomy with a conservative approach, and a better preservation of the mucosa. Although unidextrous way of operating with the endoscope has a shortcoming like this, where the scope gets blurred every time. It's difficult to perform an ossicular reconstruction. We don't have optimized otoendoscopy instruments as of now, and drilling can be challenging because of the constant staining of the endoscope with blood, bone dust, and irrigating solution. Although, with the advent of EndoHold, I think these shortcomings also hold a bright future. Microscope. Endoscopic view of the social recesses and the sinus tympani region and the round window subiculum ponticulus with the angled endoscope has a very good view as compared to microscope, which has a comparatively straight illumination where we have to maneuver the head of the patient to observe these areas. So to conclude, the use of endoscopes as an adjunct to microscopes in mastoidectomy surgeries has improved the precision of disease clearance from hidden areas, making them less invasive and more effective. Hence, using both individually incredible tools to complement each other rather than compete may be the way forward. These are my references. Thank you.
So you showed two pictures, comparative pictures, one endoscope and one
Yes,
endoscope-assisted microscope
Yes, sir.
next to one another.
Yes, sir.
And the microscope one was, in the picture that you showed was not dry, whereas the
Yes.
endoscope-assisted one was dry.
Yes, sir.
So if you were given, or if you had used endoscope for that patient in whom the microscope one was wet
Yes.
cavity,
Yes, sir.
what is it that you would have expected when had you used an endoscope there for that particular patient?
Yes, sir. Thank you for your question, sir. Sir, if we would have used an endoscope intraoperatively to assess the middle ear or hidden areas where most of the time granulations are left behind, like the oval window region or the sinus tympani region, or the facial recess where many surgeons don't tend to intervene a lot, then maybe we could have removed those and the patient would have had an epithelialized cavity early. The patient who got operated with conventional microscopy, yes, eventually they do have a dry cavity, but we would have expected better results if better assessment was done, and even the last bit of the disease would have been removed with the good visualization with the endoscope or an angled endoscope if you would have introduced intraoperatively.
Okay, thank you.
Thank you, sir.
Okay, thank you, Dr. Surabhi. Now we move to the next paper.
May I call on Dr. Gautam Sanjay Purohit?
Good morning, everyone. Myself, Dr. Gautam Purohit. My today's topic is oral submucous fibrosis. My experience with the surgical management of this challenging entity. So this is the national bird, this national animal, national flower. And day to day you see this is the national mouth of the India because of many tobacco and tobacco related products. So oral submucous fibrosis is the potentially malignant, chronic and debilitating disease with multifactorial etiology. The Pindborg in 1956 defined submucous fibrosis as an insidious chronic disease affecting any part of the oral cavity and sometimes the pharynx. The malignant transformation rate of 70 to 30% with long-term follow-up studies reporting almost 7.6% malignant transformation rate to squamous cell carcinoma. The treatment is dependent on the stage of the disease as well as the patient's symptoms, from the conservative medical management to the surgery. So aim here is to evaluate the outcome of surgical management we are doing, that is fibrotomy, coronoidectomy and nasolabial flap reconstruction. We included patients with stage 3 and stage 4 submucous fibrosis who were previously treated conservatively with no satisfactory improvement in mouth opening and who are willing for surgical intervention. Patients who have stopped consumption of tobacco and other products for at least 3 months for better surgical results. Till now we could include 6 patients because not many patients undergo surgical management and they are not ready for surgical management for fibrosis. It's a challenge to convince them. So we measured preoperatively intraoperative mouth opening with the help of vernier caliper, then postoperative 6 weeks and 12 weeks. And the most recent functional classification of grading which is proposed by Passidi et al. Is used. Like grade 1 is mouth opening up to 35 millimeter. Grade 2 is mouth opening from 25 to 35 with a 33% reduction in cheek flexibility. and so on. And grade 4 is mouth opening less than 15 millimeter or nil. So these are the various other classifications like clinical histopathological classifications. So now the surgical procedure, the first step is measuring all the patients intubated with the help of fiber optic nasal intubation because of the trismus. This is the first step of fibrotomy of the releasing fibrous bands from retromolar trigon to anteriorly. We elevate mucosa all around and we identify the coronoid process with the help of blunt dissection, cautery dissection. And once we identify coronoid, we can take cuts with the help of micromotor and chisel hammer. 2 cases we did under Siam guidance to exactly check the site of coronoidectomy, whether it's correct or not. Then we reconstruct this is called, we call it the banana flap. We keep the pedicle over here, both nasolabial flaps we elevate above downwards and below upwards. We keep pedicle like this. Lower flap will go inside and it will go posteriorly, and the upper flap will come anteriorly like this. And intraoperative, this is intraoperative suturing. So this patient which had at least 1 millimeter mouth opening, it went up to 2.3 centimeter. This is 6 weeks post-operative picture with fair cosmetic scar. This is the check X-ray post-op to check the site of coronoidectomy. Then we give physiotherapy post-operative, then maintenance medicines like antioxidants, multivitamins. The mean age was 45 years. The patient ranged from 30 years to 55 years. These are the mouth opening status preoperatively and postoperatively. The least mouth opening was 1 millimeter, which improved up to 25, and the most was the 18 millimeter, which improved up to 36. That it went above the grade 1. So these are the preoperative gradings. Out of 6, 1 patient was grade 3, all others were grade 4. So pre-op mean mouth opening was 10.5 millimeter. Post-op mean mouth opening went up to 32.6 millimeter with the p-value of 0.00002. Because of maybe less number of patients and we have used only single arm for comparison, it has come statistically, very statistically significant. This is the pre-operative mouth opening. Same patient post-operative mouth opening. Patient is very happy. Both patients are happy. The limitations of my study are this number of patients till date, needs more long-term follow-up. Quality of life, like functional outcome, is not measured in objective way like EORTC quality of life questionnaire, and all patients are male till now. So this is the conclusion. This is the effective surgical method in grade 3 and grade 4 submucous fibrosis who are not responding to conservative lines. Good functional outcome, single stage cost effective procedure, and cosmetically acceptable scar than the debility of submucous fibrosis. These are my few references. Thank you.
Sir, any questions?
What was the conservative method that you told you tried before the OT surgery?
Sir, conservative method, we injected the triamcinolone injection and the retromolar trigon, then physiotherapy and all the antioxidants, antifibrinolytic agents, and at least tried for 2 to 3 months. And when the patient presented to us, this was already tried at other centers, the medical line of management. We injected the kinocort, tricort injection.
And what was the longest follow-up?
We have followed up now till 3 months. We have recently started this study. In this year, 1 year, we have started doing these cases.
When are you completing your post-graduation?
Post-graduation, sir, I completed in 2015.
Oh, you finished already.
And I did
a
fellowship in head and neck surgery.
Super.
And now trying to venture in submucous fibrosis.
Have you tried, have you heard of contract tubex? As a conservative management. Have you heard of it before?
I have heard it, sir, but...
Not as a OSMF, not for oral submucosal fibrosis?
No, sir.
Not
I heard, but I am not sure the uses.
But you have heard of it for a scar, but you have not used it for
Yes, the facial scars.
When the first case was operated,
Maybe 1 year back, sir.
that's what the longest.
Longest follow-up
Yes,
is
but what happens, these patients, they are from periphery. So we lose follow-up. So maybe longest follow-up might be up to 6 months at present. But when they don't turn up letters.
But that is so important.
Yes, sir.
For long-term follow-up.
Long-term follow-up.
See the outcome.
Yes, sir.
Thank you.
Thank you, sir.
Okay, thank you. Now we call the next presenter, Dr. Rashmi Thakur. Her topic is Transforming Rhinophyma, Easy Solution for Better Outcome. Dr. Rashmi Thakur.
Sir, my topic is different, sir. I have told them to change it. It's on submental intubation. Yeah. When a patient with maxillofacial trauma comes to the casualty, the first priority of the casualty doctor is to ensure that the airway is secure. Once this is done, patient is referred to ENT, plastic or maxillofacial surgeon. Managing the airway doesn't stop at this stage, but it continues throughout intra-op, pre-op and post-op period. There are various ways to secure the airway, like there are various ways to skin a cat. Oral intubation is not an option in such cases because we need to check for occlusion intra-op. Rather, nasal intubation, retromolar, submental intubation or tracheostomy can be used. Submental intubation is not very well known amongst ENT surgeons, but it is a small effort to bring it to the attention of others. Good morning, I'm Dr. Rashmi Thakur. I'll be presenting my paper on submental intubation in maxillofacial trauma, a 2-year study in 10 cases. Submental intubation is a technique in which endotracheal tube is passed through the floor of mouth to exit through the skin of submental space. It allows free intra-op access to oral cavity and nasal pyramid. It was first introduced by Hernandez Altamir in 1986. Let's see where we can do submental intubation. In cases where nasal intubation is contraindicated, like in cases of CSF rhinorrhea or epistaxis, nasal bone fracture, or in cases of panfacial fractures, Leaford 2-3 fractures, or if there is any intranasal pathology, or in cases of facial cosmetic surgery with rhinoplasty. So why do we need submental intubation? Because it provides clear field for both the surgeon and anesthetist. And also, it allows intra-op occlusion correction, as in cases of facial fracture, we need to do maxillomandibular fixation for proper reduction of the fracture. And it provides access to both oral cavity and nasal pyramid when we can't do oral or nasal intubation, thereby avoiding the need for tracheostomy. So when should we avoid it? If the patient needs prolonged ventilation, or if there is any need for repeat surgery, or if there is any severe neurological deficit. So the purpose of our study was to review the outcome of submental intubation in maxillofacial trauma patients. So this is a retrospective study done between Feb 2022 to Feb 2024. There were 10 male patients between the age of 18 to 65 years, and inclusion criteria included maxillofacial trauma patients where nasal intubation was not possible, and exclusion criteria included neurological deficit, thoracic trauma, or repeat surgeries. So the procedure starts with standard orotracheal intubation with armored ET tube. Universal connector of the ET tube is replaced with a removable one, and after proper painting and draping of the submental area with the proximal end of the ET tube and the pilot balloon, a 2 cm incision is made 1 finger breadth below the lower border of the mandible, and a tunnel is formed by doing blunt dissection with a curved artery forceps. And intraorally, a small incision is made over the floor of mouth overlying the tip of the forceps. And before disconnecting the ET tube with from the breathing circuit, 100% pre-oxygenation should be performed. And with the forceps, deflated pilot balloon is brought down first, followed by ET tube, and anesthetist confirms the position of the ET tube by confirming bilateral air entry, assessing end tidal CO2, and the tube is secured to the submental region. This is a video showing submental intubation in Leaford fracture. You can see how the incision is being taken and a tunnel is being formed with the forceps, and how the pilot balloon and the ET tube is being brought down to the submental region. Let's look at the results of our study. 70% patient had Leaford 2 with NOE with mandible fracture and 30% patient had Leaford 3 with NOE with mandible fracture. Average duration of the procedure was 4.8 minutes, and we didn't experience any difficulty in passing the tube through the incision, and there were no intra-op complication. All patients were extubated on the same day. There were no post-op complication, and intraoral and external wound healed really well, and the scar was acceptable by the patient. So let's discuss why submental intubation can be considered an excellent alternative. It offers less invasive solution as compared to tracheostomy for short-term airway management, and it provides unobstructed field for both surgeon and anesthetist with minimal interference from ET tube. So let's see what are the problems with other airway techniques. Nasal intubation is an excellent option, but there is a risk of cranial intubation in cases of skull-base fracture, and it does not provide access to nasal pyramid, making treatment of mid-facial fractures challenging. And also it is not feasible in cases of congenital or acquired nasal deformities. Retromolar intubation is also an option, but it does not provide enough space and it interferes with oral surgery, and there is a risk of accidental extubation. Tracheostomy, though often used, has its own drawbacks, like there can be emphysema, pneumothorax, RLN injury, unsightly scar, or tracheoesophageal fistula, or tracheal stricture formation. Submental intubation addresses many of this issue, although rare, but there are some complications associated with it, like infection or abscess formation can occur, or lingular injury or damage to Wharton's duct, or mucosal or salivary fistula formation. As we have seen the benefits and complication of submental intubation, let's directly compare it with tracheostomy. With submental intubation, we require really less time, and there is no post-op care required as compared to tracheostomy. And also the major complication we have seen with tracheostomy, it is not there in submental intubation. The scar is also acceptable, and it is cost effective, although it is for short-term ventilation. To conclude, I would say submental intubation is a quickly learned and mastered skill. It does not require any specialized equipment, and it reduces overall surgery time, and it is associated with very low morbidity. Submental intubation is thus a recommended elective approach for ENT surgeon. It's like a new weapon in the armory of ENT surgeon. Thank you. These are the references.
Sir, questions?
So who did this intubation? Is it by the anesthetist or the ENT
Yes, sir,
surgeon?
surgeons have to do this.
And it is...
I mean, first orotracheal intubation is done by the anesthetist, then the submental tunnel is being formed by the surgeons only.
when the patient is extubated?
So most of the time it is extubated on the same day, and it is for short-term ventilation, sir. So max to max, it should be less than 7 days, sir. Like, yes.
Fine, thank you.
Thank you, sir.
Thank you. So I call the next person, Dr. Manali Joshi. Her topic is a study of subjective assessment of improvement of nasal symptoms following septoplasty versus septoplasty with inferior turbinoplasty by nasal scale. Okay, start.
Good morning, Chairperson, judges and the audience. My topic of presentation is a study of subjective assessment of improvement of nasal symptoms following septoplasty versus septoplasty with inferior turbinoplasty by nose scale. As you all know, nasal obstruction is a common presenting symptom which an otolaryngologist encounters in daily practice. It affects 9.5 to 15 of general population. It is one of the most common cause of nasal obstruction is deviated nasal septum. Deviated nasal septum towards one side is often associated with compensatory hypertrophy of inferior turbinate on the contralateral side. Many authors believe that once septoplasty is done, compensatory hypertrophy of inferior turbinate regresses on its own. Some authors suggest that hypertrophy involves bone and as well as mucosa, and suggested that these changes are reversible and should be addressed in conjunction with septoplasty. Mucosal hypertrophy of turbinate is thought due to the clinical inflammators like that of allergic rhinitis, rhinosinusitis, which can be medically managed. Conversely, osseous hypertrophy of inferior turbinate, secondary to septal deviation and refractory to medical management, can be surgically corrected along with septoplasty. Various other methods are available for assessing this obstruction of nasal obstruction in clinical practice, which are subjective and objective. Objective tests being rhinomanometry and acoustic rhinometry. It is difficult to carry out this procedure in daily practice, and hence subjective evaluation was introduced. A nose score is a subjective method of assessment of nasal obstruction, which is based on questionnaires, which gives better assessment of symptom severity and quality of life. My aims and objectives are to compare the symptomatic improvement of nasal symptoms following septoplasty with inferior turbinoplasty versus septoplasty alone in group B. To assess the subjective improvement of nasal symptoms in group A and B before and after surgery by nose scale. This is a randomized control trial in a tertiary hospital conducted for a duration of 6 months, where 60 cases of septal deviation and contralateral inferior turbinate hypertrophy were selected. Written and informed consent was obtained from the patients before study enrollment and alternatively distributed to Group A and Group B. The nose scale was used for subjective evaluation, and post-operative symptoms were evaluated on first, third, and 6 months respectively. Data and test of significance was analyzed by chi-square test, and SPSS version 7 software was used for data analysis. The patients of group A underwent septoplasty with turbinoplasty, where decongestion of nasal mucosa was done, septum was infiltrated, and a glance incision was taken, mucopericardial flap elevated, anterior and posterior inferior tunnels created, 2 mm strip of cartilage and posterior bony deviation was removed, followed by turbinoplasty, which was done by microdebrider technique with lateral aspect of mucosa, and 1/3 of the turbinates of bone was removed. Group B patients, which is septoplasty alone, same steps were followed. Nasal pack was removed in both the patients on the second post-operative day, and follow-up was done on first, third, and 6 months. Relief from the nasal obstruction was assessed using nose score. Pre-operative and post-operative nose score was compared between both the groups. My inclusion criteria included unilateral nasal deviation and compensatory hypertrophy of contralateral inferior turbinate, age between 18 to 65 years, and the exclusion criteria was age less than 18 years, DNS with bilateral turbinate hypertrophy, previous history of nasal surgery, and acute and chronic inflammatory nose and paranasal sinuses, pregnancy. This is a nose scale which has 5 questionnaires. First being nasal obstruction, nasal blockage, trouble breathing through my nose, trouble sleeping, unable to get enough sleep through the nose. These were rated from 0, which is minimum, to 4th, which is maximum severity. The addition of all the 5 divided by 20 to get a percentage, where they were graded at 0 with no obstruction, 5 to 25 with mild obstruction, 30 to 50 with moderate, 55 to 70 with severe, and 80 to 100 with extreme. In this study, total 16 patients were selected, where 41 were males and 19 females. Group A patients which went septoplasty with inferior turbinoplasty, male to female ratio was 1.5:1, and in Group B it was 3.1:1. In this study, males outnumbered the number of females. This is the mean standard deviation symptom-wise nose score, where the mean deviation is calculated pre-operatively for 1 month, 3 months, and 6 months post-operatively. Here, the p-value was less than 0.001, which suggested highly significant result favoring Group A over Group B, and p-value, which was shown 0.05, suggested no statistical significance. Hence, the results were post-operative improvement of nasal symptoms in both Group A and Group B was highly significant at post-operative first, third, and 6th month. When both the groups were compared, those undergoing inferior turbinoplasty with septoplasty had highly significant results and improvement of nasal symptoms. The present study was carried out to know whether septoplasty alone can treat nasal obstruction or whether hypertrophied inferior turbinate needs to be addressed. No scale was used. Patients undergoing septoplasty with turbinate has a better improvement of nasal symptoms in nose score as those compared to the septoplasty alone over a period of 6 months. Poisson's law states that airflow through a tube is proportional to the fourth power of radius or to the same of the cross-sectional area of the tube. This means that slight variation in the size of soft tissue or bone of the inferior turbinate can have a large effect on nasal airflow. Hence, so reducing the inferior turbinate at a time of septal surgery improves nasal passage and gives better relief of nasal obstruction post-operatively. While performing the surgery, one should take care that not to remove excess of inferior turbinate, which hampers the physiological function of nose, leading to excess drying, crusting, and a long-term atrophic rhinitic changes. Failure to reduce the size of turbinate at a time of septal surgery may result in persistent nasal obstruction. Similar studies as mine were conducted by the solvers like June et al. And Velasco et al. To conclude, our study showed that the unilateral hypertrophic nasal needs to be addressed in cases of nasal obstruction, and quality of life were better in those patients who underwent septoplasty. Post-operative follow-up nose score was significantly lower in patients who underwent inferior turbinoplasty at time of septoplasty. In routine septoplasty, surgery addressing inferior turbinate improves post-operative nasal symptoms, and nose scale can be used as a subjective assessment tool for pre- and post-operative documentation and follow-up. These are my references. Thank you.
Judges, any questions?
So after this study, what is your decision for your own practice when it comes to doing septoplasty? You will always do the same septoplasty with turbinate surgery, or you will still have some cases where you will do only septoplasty?
No, sir. Depending on the depending on the nose score, which I'll give to the patient, depending on which I will decide to go for septoplasty with turbinoplasty pre-operatively.
Can you take one example of a patient and decide in whom, what decision you are going to make?
If the person has marked DNS to one side and inferior turbinate hypertrophy, grade 3 to grade 4 of inferior turbinate hypertrophy on the contralateral side, I would like, and complaints of nasal obstruction, I would go for septoplasty with inferior turbinoplasty. Thank you.
Why cases with bilateral inferior turbinate hypertrophy are excluded?
Sir, because that affects the nasal cycle, sir. Patient, if both the sides of turbinate were removed.
But you are doing a partial resection and not complete removal.
Yes, sir.
So don't you think that keeping the hypertrophic turbinate on the side of deviation will affect the quality of life later on?
No, sir. So that's why we are doing it on the compensatory side.
Did you come across any complications in these cases?
So initially 1 or 2 cases of epistaxis were there, sir, which were, it later got treated, but yeah, epistaxis was most common complaint.
Any incidents of adhesions in a
yes,
long-term
there
follow-up?
were incidents of adhesions in 1 to 2 cases also, which were later corrected. So.
Fine. Yeah.
Thank you.
Thank you.
Okay, thank you, Dr. Manali. Now we call for the next speaker, Dr. Anoushka Sahai. Her topic is endoscopic management of congenital encephaloceles, our experience. Right? Yes, please start.
Mind is not a vessel to be filled, but a fire to be kindled. And endoscopic sinus surgery ignites this fire of innovation, exploration, and advancement in the field of ENT. A very good morning, everyone. I, Dr. Anoushka Sahai, am present before you to give my talk on endoscopic management of congenital encephaloceles. Meningoencephalocele is defined as the herniation of brain and meningeal tissue through the defects in the calvareal skull. This herniated brain tissue is non-functional. This is because of various factors. The first and the foremost being the persistent CSF leak causing hampering of the nutritional supply. Secondly, due to the expulsion in the nasal cavity, there is increase in the mechanical pressure that leads to the reduction in the blood supply. So congenital encephaloceles usually present in the early childhood. They can be classified as basal, sincipital, and occipital. During embryogenesis, what happens is there is failure of the closure of the anterior neuropore, and this leads to the development of a meningocele, which is the herniation of just the meninges, or a meningoencephalocele, which is the herniation of meninges as well as the brain tissue, as can be seen in this animation. So we present a study consisting of 4 patients, all of pediatric age group, with basal encephaloceles, whereby all of them were of spontaneous onset. We must note that the basal encephaloceles are the ones which are amenable to the endoscopic approach, and that is what we have considered in the study. So these children present with nasal obstruction or a nasal mass. Interestingly, a defect which is present during embryogenesis presents late. This is because the herniation takes time. Patients can present with CSF rhinorrhea. Very rarely, patients present very late, and this is when they can have meningitis. So what are the challenges associated with this age group? Firstly, the risk of general anesthesia. A multidisciplinary coordination between a pediatrician, a pediatric anesthetist, as well as an ENT surgeon is must. Secondly, there is a lack of space for instrumentation. A lot of surgeons advocate the use of a 2.7 mm endoscope. However, in our study, we have used a 4 mm endoscope, but of course, with the use of ear instruments. So this animation as well as the video gives an overview of how such patients are managed at our institute. The non-viable tissue is first reduced with the help of a cautery. Then the edges of the defect that needs to be repaired are made bare. Finally, the defect needs to be packed. As you can see, a bath plug technique is used. Then a cartilage is being placed on the same defect. The surgeon must not conclude the surgery unless a tight seal has been achieved, which must be ensured by giving a Valsalva maneuver intraoperatively. Finally, we pack it with the help of a fascia lata graft, and finally the tissue glue is placed. So, in our study, all the patients had a defect in the cribriform area. This is an identified anatomically weak site, well corroborated in the literature. 3 of our patients had a medial lamella meningoencephalocele. This is a scan of one of our patients where a soft tissue density is seen in the left nasal cavity, medial to the middle turbinate, pushing the septum to the opposite side. This is the intraoperative video of the same patient, whereby a pulsatile glistening mass is seen, which is indicative of a basal encephalocele. So we go ahead and identify that the encephalocele was in fact present medial to the middle turbinate, which will be highlighted in yellow. Then the encephalocele is reduced with the help of a cautery. The edges can be made clean carefully with the help of a debrider. The defect site that needs to be repaired should be measured. These children have a growing skull, so we cannot go ahead and excise a lot of cartilage. So we just incise a small cartilaginous septal window. This is made to size, and finally this is used to repair the defect. And finally we put a fascia lata graft and tissue seal. So encephaloceles can be reduced with the help of a coablator. One must remember that a vessel passes through these encephaloceles and bleeding can be encountered. So this is an MRI of one of our patients with left-sided medial encephalocele. After identifying all the attachments of the encephalocele was reduced with the help of a coablator. So the coablator works on the principle of low temperature radiofrequency that disintegrates the tissue. So as the coablator wand moves along, it coagulates, it ablates, and it suctions the fumes which are generated, thus acting as a 3-in-1 action in the hands of a surgeon, thus reducing the operative time for the patient. One of our patients had a lateral lamina meningoencephalocele, which is a very rare find. These are the scans for the same patient. So by showing this video, I want to highlight the importance of scoring of cartilage for these patients as it improves the maneuverability of septal cartilage. This is a specimen of the same patient, and finally, this is the post-operative scan of the patient at 1 month. So we must remember that these children do not understand the importance of nasal packing. So we advocate giving a boxer dressing to these children in the post-operative period. On a lighter note, this is a video of one of our patients who was operated the very morning. The video was taken in the evening. Definitely, the child believes that all rest and no play makes recovery a rather dull journey. So all our patients were operated and the defect site was closed in multiple layers. So there are some limitations associated with endoscopic approach. We can't operate syncypital encephaloceles solely endoscopically. A plastic surgeon and neurosurgeon must be included in the team. Another is that a large anterior skull base defects, as can be seen in the scan, should be repaired with the help of a neurosurgeon. So, transnasal endoscopic approach provides good visualization, there is no scar remnant, and reduces the morbidity. Since there is no cerebral retraction, there is faster recovery, and this also prevents anosmia. So, just like it said, all that glitters is not gold. In the same way, all that protrudes from the nose is not a polyp. One must consider the diagnosis of encephaloceles, especially in pediatric patients. Thank you.
Sir, questions? Okay, thank you. Now we call for the next speaker, Dr. Shivani Dixit. Her topic is correlation of laryngopharyngeal reflux disease and voice disorder, prospective study. Okay, you can start.
Good morning, all of you. Now, imagine doing this all day long with the voice disorder. It is so much of deteriorating thing, excessive coughing along with the voice change. With this, I'm going to start my topic of correlation of laryngopharyngeal reflux disease and a voice disorder, a prospective study. As we all know, LPRD is an inflammatory condition which is defined as a backflow of the gastric contents into a laryngopharynx, and it accounts for approximately 30% of patients who visit to ENT departments. The reflux theory explains that LPR develops from the microaspiration of acid, bile acids and pepsine that can directly injure the larynx and cause the symptom. As we all know that 24-hour dual probe ambulatory pH monitoring is considered to be the gold standard method for diagnosis of LPR, but some studies have reported that it is partially invasive, expensive and has a limited use in the outpatient department. So to facilitate the diagnosis, a useful, available and a validated self-measurement tool was developed by Belafasky et al., that is Reflux Symptom Index, for a subjective assessment of LPR, and a clinical scale, that is a reflux finding scale, which assesses the severity of the mucosal injury that were found in endoscopic examination of larynx. So the aim of my topic is to investigate a comprehensive correlation of LPRD and voice disorders, and the objective was to assess the clinical diagnosis of LPR in a patient presenting with a voice-related problems to the correlation of RSI and RFI. It was a prospective study which was conducted between July 23 to Feb 2024. Total 60 patients were included in the study. All the adult patients with a voice change of 4 weeks and attending the ENT clinic for the voice disorder were included in the study. Patients who were excluded were patients with the organic laryngeal pathologies, with voice abuses, previous radiotherapy, and patients who were already taking the proton pump inhibitors for minimum 2 to 4 weeks. The study was conducted on all the patients coming to the tertiary care hospital, and the consent was taken. Detailed history was elicited with thorough ENT examination. All the patients were subjectively evaluated for their voice problem using the reflux symptom index, and video stroboscopy findings were noted and reflux finding score were calculated. So this is a reflux symptom index. More than 7 was considered to be significant, and a reflux finding score more than 13 was significant. So this is some of the pictures of video stroboscopy showing the arytenoid edema, then pachydermia, subglottic edema, and a ventricular obliteration. Another pictures showing bilateral arytenoid edema, ventricular obliteration, pachydermia, and again arytenoid congestion. Results. So maximum number of patients who were suffering from LPR and voice change were between 51 to 60, approximately 38.3% patients, and more commonly it were female. Approximately 62% of females were having LPR with voice change. So most common symptom which was detected on RSI was hoarseness of voice. Approximately 60% of patients were suffering from hoarseness of voice, followed by chest burn, and the least common symptom were choking episodes and difficulty in swallowing. The most common finding, physical finding on RFS was encountered to be the arytenoid edema. Approximately 91% of patients were suffering, were having arytenoid edema, followed by posterior commissure hypertrophy, followed by thick mucus. And the least common were diffuse laryngeal edema and ventricular obliteration also. RSI-RFS correlation was done using a simple multivariative regression analysis, and RFS was found to be positive in 46 patients out of 60, and RSI was positive in 50 patients out of 60. So there was a significant statistical correlation between the sum of the patient's symptoms of RSI and the laryngoscopic findings of RFS. These are some other studies, similar studies which were done by Daud et al. And Karyakia et al. Same patients had most common symptom was change in voice, and their most common finding was posterior commissure hypertrophy along with the vocal fold edema, whereas in our study, change in voice again was the most common symptom, but arytenoid edema and posterior commissure hypertrophy were the most common finding which was found. So, to conclude, diagnosis and the treatment of LPR disease has been subjected to various controversial issues, and even the gold standard, that is pH monitoring method for its diagnosis, has been questioned by several authors who concluded that it does not have a 100% sensitivity. Our study reveals that hoarseness is the most common symptom and arytenoid edema is the most common finding detected, with the highest positive correlation between them. RFS and RSI are easy. They are quick and outpatient screening tools, and when used together are more reliable for the LPRD diagnosis. So the take-home message is laryngopharyngeal disease significantly impacts the voice quality, with reflux symptom index and reflux finding score can be serving as a crucial diagnostic tool. Voice change are not just symptomatic, but can be quantifiable indicators for underlying laryngopharyngeal disease. And multidimensional assessment through RFI and RSI offers more accurate diagnostic approach. These are my references. Thank you.
Any questions?
Is there any grading of severity depending on these two scores? How exactly it helps in the clinical practice?
So, sir, patients coming with a voice change and has some underlying LPR features, the video stroboscopy is done, and we see the LPR features on the larynx, such as arytenoid edema, pachydermia, subglottic edema, and accordingly then the severity, there is no as such scope for like putting a quantifiable thing for the severity, but we see that there is a condition, there is a lot of edema which is causing a voice change, and then we go ahead with the treatment part. But there is no as such a severity scale which can be put on the video stroboscopy findings.
So you mean to say that rather than going for that pH monitoring, only symptoms and this clinical examination finding score?
So it is more reliable and more easy and quick thing to do on an outpatient basis. Yes, of course, pH monitoring is the gold standard, but not all of the centers have this pH monitoring since it's invasive and very expensive. So even in the patients are not that much competent enough to pay for the pH monitoring. So this is the most easy and reliable diagnostic tool which can be used and treatment can be done.
Thank you.
Thank you, sir.
Okay, thank you. Now we call for the next speaker, Dr. Meena Vishwanath Kale, and the topic is defensive strategies for preservation of vision in orbital trauma, our design of approach.
Good morning all. Today I am going to present the defensive strategy in the prevention of vision deterioration in orbital trauma, our design of approach. I like to ask you, how would you like to see the nature? Like this, the double disturbed blurred vision, or like this, the normal vision? Obviously, the normal vision is preferable. The vision is an important perspective from the ENT point of view. Why so? Because they are our neighbor. As we know, the orbital globe is protected by the bony pyramid containing extraocular muscle along with their facial sheath, ophthalmic artery, vein, which are attached to the orbital wall and which prevent the anterior subluxation during trauma. Whenever there is a trauma, it expands anteriorly. Why so? Because of the minimal resistance offered by the orbital septum and the open space. Let's see the mechanism of orbital trauma. Whenever there is a sharp object, it definitely causes the vision deterioration. But in the blunt trauma, if the blunt object is larger than the orbital rim, it will cause the orbital wall fracture. And it is smaller than the orbital rim, which will cause the ocular trauma. It will manifest as the hydraulic trauma, which causes the blowout fracture, while the direct damage to the globe causes the buckling of the globe, which increases the intraorbital pressure and causes ultimately fracture. We know the medial and inferior walls are the weakest wall, which usually gives way and act as a safety mechanism for the prevention of the compartment syndrome. My objective is the rectification of the varied orbital trauma by nasal endoscopic approach. We have done the retrospective study of 63 cases of orbital trauma in 6 years in our tertiary care hospital. Results were calculated by the percentile method. Please note that the vision deterioration in my study means the diplopia, blurred, or diminution, or the loss of vision. Let's share our experience with the orbital trauma. I'll explain all the cases one by one. As we know that the ocular motility disturbance is mainly because of the functional disability of the muscle. It may be because of the neurogenic paralysis, muscle entrapment, or restriction of the mobility due to hematoma. Let's see the case. This 40 years old female had the left eye blunt trauma, developed diplopia and the restricted movement. She also had the restriction in adduction, restriction in abduction, as well as development of the pseudostosis, apparent globe retraction, narrowing of the palpebral fissure. It's called the pseudodines retraction syndrome. When we did the CT scan suggestive of the medial orbital wall fracture, medial muscle rectus muscle entrapment, orbital flat prolapse. We have done this patient, we have taken patient for the surgical exploration with the orbital decompression, removal of the fracture segment, reposition of the fat and the medial rectus muscle. Patient has been improved in the adduction as well as abduction, correction and pseudostosis. The correction of pseudodines retraction syndrome has been done after the surgery. The medial and the inferior orbital walls are the thinner, but still the inferior blowout fractures are more common than the medial. Why so? Because of the Merle et al. Study. As the Merle et al. Study has says, the medial orbital wall is strengthened by the perpendicular septa of the ethmoidal air cells. Hence, the number of ethmoidal septas are inversely proportional to the frequency of the fracture. In this case, patient has developed diplopia, restricted eye movement with the medial and the inferior orbital wall fracture with the fat prolapse and the development of the pneumo-orbit. We have taken this patient for the medial and the inferior orbital wall decompression with the removal of the fracture segment. There was non-availability of the titanium mesh and Durapore. We have used the septal cartilage, which wedged with the Foley's catheter inflation for 2 weeks to give the support to the new inferior wall of the orbit. This bacho, while fighting with his colleagues, had developed bilateral orbital hematoma. The left was non-expanding. We have managed it conservatively. While right was expanding, the CT scan was suggestive of subperiosteal hematoma. We taken the patient for the orbital decompression and the drainage of hematoma. This patient, while 35 years old male, while drilling on the road, has drill bit had hit to his eye and developed the complete vision loss. We taken this patient for the orbital decompression and the removal of the foreign body. This patient, young adult male who had developed the raccoon eyes along with the active CSF leak with the planum fracture and the optic nerve canal fracture. We taken this patient for the optic nerve decompression, and since the patient was having active CSF leak, we have repaired at the same time with the fat, tensor fascia lata graft, tissue glue and the Surgicel with gel form. We didn't pack his nose because we have done the optic nerve decompression. This case, after 15 days of blunt trauma, he has developed the restricted eye movement, diplopia, ecmosis, chemosis, diminution of vision. Initially, we were suspecting the patient had developed cavernous sinus thrombosis, but since the patient having pulsatile exophthalmos and the MRI was suggesting of early draining vein, to confirm it, we have done the DSA. On DSA, it was suggestive of early draining vein. So, we have made the diagnosis of caroticocavernous fistula. We have taken this patient for the embolization with the PVA material. Patient has been significantly improved on the post-op day 1 only. In this case, we have kept the endoscopic approach as a standby. Just for a small video for the same slide. As this slide is specifically showing this thing, sometimes by not doing anything is also a good job to do. So as we have kept this endoscopic approach for this case as a standby. To review our experience, we have done the 8 weeks of post-op follow-up for the vision improvement. We have seen near all the cases has given around 100% reason for the vision improvement, except the foreign body and the optic nerve trauma, which has given us the satisfactory result. Hence, to conclude that blunt trauma can be as disastrous as the penetrating trauma. In the old era, the conservative approach was preferable with the antibiotic and steroid. That was the need of that time. But nowadays, with the improved equipments, magnified endoscopic system, high resolution image, combination with the navigation and interventional radiology, combined team effort with the ophthalmologically, for better understanding and the detailed anatomy can be very rewarding. The endoscopic strategy has made the treatment highly improved to a further level with better efficacy and the fast recovery of the orbital trauma. These are my references. Thank you.
Sir, questions? The next speaker, Dr. Priyank Talati, is not present. He is absent. So we go to the last speaker, Dr. Amish Vaklu. His topic is allergic rhinitis and effect of sublingual immunotherapy on clinical symptoms.
Good morning, everyone. Good morning, respected judges. So today I will be speaking about allergen immunotherapy and its clinical efficacy on allergic rhinitis. So we all know allergen immunotherapy is a disease-modifying therapy which is extremely effective for allergic rhinitis, conjunctivitis, as well as allergic asthma. It involves an administration of an increasing dose of allergens which aims at ameliorating the allergic response. The two most commonly used routes are the subcutaneous immunotherapy and the sublingual immunotherapy. So why is sublingual immunotherapy better than subcutaneous immunotherapy? Because it's safer, it is easy to administer, and there is a reduction in the presence of severe adverse reactions. So allergen immunotherapy usually acts by developing an immunotolerance by converting the Th2 mechanism to a Th1 mechanism. So the aim of our study was to study the efficacy of allergen immunotherapy on the clinical symptoms of allergic rhinitis. Patients between the age of 5 to 65 years who were suffering from allergic rhinitis were included in our study. The exclusion criteria included children below the age of 5 years, patients with severe immunity disorders, patients with severe asthma who had an FEV1 less than 70%, and pregnant women. So the most important part in diagnosing patients with allergic rhinitis is to take a very good clinical history. So we took the SNOT-22 questionnaire, which includes 22 questions with a severity of 0 to 5 for each question. So the minimum score is 0 and the maximum score is 110. So a score of more than 40, we used to go ahead for a skin prick test. After the skin prick test, the most important thing is to take a second history. You have to go back to your history. You have to ask the patient whether the sensitization that has come on the skin prick test correlates with the history of the patient. Otherwise, the skin prick test is practically of no use. And after you have a second history, you can start your sublingual immunotherapy. So here we see two images of one image. The first image is of a skin prick test. So we use histamine and normal saline as a positive and a negative control. And depending upon the history of the patient, we can test for various allergens. And the second picture that you see is a patient taking of sublingual immunotherapy. So the observation and discussion, we had a total of 62 candidates from between the age of 5 to 65 years. It included 25 male and 35 female candidates. 2 candidates were lost to follow up because they were not compliant with the vaccination. So most of the patients had a prolonged duration of allergic rhinitis, approximately 3 to 5 years. Whereas only 8 patients had an allergic rhinitis symptoms for 6 months, sorry. So we have divided the duration of vaccination. Most of our patients, what we do is we give them the vaccination for a duration of 1 to 2 years, mostly for a duration of 2 years. Depending on that, depending upon the improvement of the clinical symptoms, we take a call whether to stop the vaccine or to continue with it for another couple of years. So based on the 4 major symptoms of patients with allergic rhinitis, we have made a study which compares the pre-treatment and the post-treatment severity of the symptoms. The 4 major symptoms that we have included are sneezing, nasal congestion, runny nose, and cough. And to our surprise, we saw that there was a significant reduction in the symptoms of these patients after starting sublingual immunotherapy. Along with that, the use of antihistaminic medication as well as steroidal sprays also reduced significantly. However, there are a few drawbacks of sublingual immunotherapy, mainly the long duration of the vaccination that needs to be given, which hinders the patient compliance. Along with that, the cost of the testing, that is the skin prick test, as well as the cost of the vaccination is pretty high, which is not affordable to almost a large section of the population of our country. So through this study, we wanted to demonstrate that the pharmacotherapy, which is continued in patients with allergic rhinitis for years together, can be reduced or discontinued completely with sublingual immunotherapy. Along with that, sublingual immunotherapy also prevents neosensitization. So in totality, sublingual immunotherapy should always be started with a low dose and the dosage should be progressed gradually. Sublingual immunotherapy is better tolerated when compared to subcutaneous immunotherapy. It is very effective in children more than 5 years of age, but the safety in children less than 5 years of age is still not confirmed. The clinical effects of sublingual immunotherapy can persist up to 5 years after discontinuation of the therapy. At last, I would like to say that sublingual immunotherapy should be considered for patients with allergic rhinitis and should always be an addition to other therapies in an allergy practitioner's armamentarium. So the future of allergen immunotherapy includes allergoids, recombinant allergen, T and B cell peptides, DNA-based vaccinations, passive immunotherapy, as well as biologicals. These are my references. Thank you.
Sir, any questions?
So once we take a good clinical history for the patient, so the patient will tell us, in a layman's language, the patient will say कि धूल से छींकें आती है, सुबह छींकें आती है, whatever the history the patient gives. After that, once we do a skin prick test, what we see a lot of times is the patient, if we do a test for suppose 50 allergens, the patient may show sensitivity to maybe 20, 30, but the patient might not be allergic to all those allergens. So it is just a sensitivity test, it will not diagnose your allergy. You always have to go back and correlate your test results with the patient. So that is called taking a second history. So if the second history correlates with your findings, Then we can go ahead with the sublingual immunotherapy.
Thank you.
Thank you.
Thank you.
Thank you, everyone. Now I would like Chairperson, sir, to felicitate both the judges. Sir, felicitate the chairperson. Dr. Surabhi, please come on the stage. Dr. Rashmi. Dr. Manali. Dr. Anoushka. Dr. Shivani. Dr. Meena. Dr. Amish.